methicillin-resistant Staph aureus. She's sitting currently up in red veils with aquatic cough treated in IV in situ. The patient is looking distressed. Color, pale with signs of central cyanosis. Her temperature is 38, heart rate 129, blood pressure 185. 100 over 85, respiratory rate 34. Her breathing is shallow, apical with active expiration. She's unable to talk due to shortness of breath and excessive cough. She's receiving 28% via venturi mask auscultation. She has a coarse inspiratory crackles throughout the chest on background of high-pitched expiratory wheezes. And palpation, she has limited chest excursion on inspiration bilaterally, and secretions are palpable in the upper and anterior chest. So, the question is, what is the multi-system involvement in CF? What is CF?
Cystic
Cystic
fibrosis.
fibrosis. So what is cystic fibrosis?
Is it the fibrosis of the lungs and possibly, I don't know if other tissues or if it's a severe.
Okay, so is it an acquired disease? Is it a genetic disease? Is it?
Genetic?
It's a genetic condition, right? And it's basically associated with abnormally thick and abnormal mucus production. What organs does it affect, and why? What is the condition? What is the condition associated with it? Does anybody know?
Does it affect the liver or?
As well, yeah. So it's a genetic mutation of what's called the transmembrane conductance regulator gene, okay? But it's basically responsible for the conduction of chloride in the epithelial cells. So you've got these channels, okay, chloride channels and sodium channels. And it involves all the exocrine glands. So usually the chloride gets absorbed into the cells, whereas in this case there's a problem with the chloride channels and it gets excreted to the surface of the skin epithelium. And you also have sodium channels, and these are intact, and they're the ones that are secreting out. So what you end up at the surface, you have chloride and you have sodium. So sodium chloride is what? Salt, NaCl, basically. So one of the tests for diagnosing CF, sometimes in the past might happen, is if a parent licks a child, it tastes salty, and that's because of the sweat, the sodium and the chloride on the skin, the salt. Okay, so it's actually a sweat test because they test the sweat in the patients, and they have an increase in the salt content of the sweat. But because you have these issues with mucus being thick, and it affects all of the exocrine glands. So you know, the pancreas, the liver, the gut, the digestive system, the lungs. So, and it's basically a very severe illness, which is lethal, right? People die from it every day at a younger age. And the mortality or the death in the past, kids did not survive past teenage years. When I was working in the hospitals, we were treating the CF kids, and they were regularly dying, you know, even before reaching their teens, or in their teens. Now with the new medications that are being produced and given to the patients, it's increased their lifespan. There's less infections. So, you know, one of the things that is typical in terms of the lungs is the increased production of secretions and then the recurrent infections. So you end up with bronchiectasis, right? Which is when you read that she normally has yellowish green sputum. That's bronchiectasis, that's layered and greenish. And then she ended up with an infection, and that's changed the color of the secretions. But they have bronchiectasis, not just in one part of the lung, it's throughout the lungs, basically. And so you have to do secretion clearance, they have to do secretion clearance techniques, 3 times a day, in order, 3-4 times a day, in order to clear the secretions, so to reduce the risk of infection. Now with the medication, they bring them to the hospital, they give them high doses of medication to kind of do the, what they call it, toilettage of the lungs, to avoid the infections, and that has increased longevity. Also, lung transplantation with the, in the 80s with the first lung transplant was a CF patient here in Montreal. I remember her, I know her. So that's also increased the lifespan. Now, if we look at the statistics, now after about 1986, there's about 90% of the people that are born with CF survive into adulthood. So we're talking past the age of 18, okay? But the median age for survival of CF has increased from 27 years, which was in 1986, to about 38 years in 2010. And think about transplant, even after having a transplant, the risk of rejection is the sort of primary problem, right? We say that about 50% of patients with a lung transplant survive 5 years. So, we're talking, it increases lifespan, but you still don't have a normal lifespan. So in terms of the organs that are affected, the skin is affected, the skeletal, the skeleton, there's poor absorption also of elements, right, through the gut. There's problem with the digestive system, which is why they take these enzymes all the time to help with digestion. That's problematic. Diabetes also, because the pancreas is affected, it's quite common that they do develop diabetes, and she was diagnosed with diabetes a year ago. Could have liver disease, osteoporosis, as I mentioned. Okay, any questions about the case? What I'd like you to do is to think about now the problem list, okay? Identify the problem list and the treatment plan. Think about, the short term, as if you come see the patient currently, what can you do? But also as, it's progressing and, her condition, whether it's hemoptysis or, her fever that she has is getting better, what do you also want to work on? And think about long-term too, right? Because there's certain things she was doing before that she stopped doing, so you have to kind of come back on that as well. Okay? Off you go. So yeah, you guys have to split somehow. 6. So maybe one of you in the back can go to this group. Do you want to join? Okay, or you? Okay.
I thought Chloe was volunteering, and then she just left. I'm like, oh, okay, guess not.
It's like when she was treating the patient, she's like, I gotta blow my nose.
Yeah, exactly.
Alright, guys.
All right, Jeremy, you want to take the lead on this one? Different how?
It's something that we've never seen before. It's clever. It's a different case. And now I think secretions is the number one problem. Right? Yeah.
Write them all and afterwards do it.
You guys want to do that? Write them all in.
Hold on. So yeah, Yeah, do secretion retention.
Third last line.
And I would put dyspnea.
And secretion also. Secretion and retention and dyspnea.
And then do this one.
At rest and on exertion.
Oh, very good.
This is at rest. Third line. She has crackle week.
Yeah, that's all part of the secretion stuff.
Which usually has this one. Horse and sexual crackle. Yeah, but she also has her respiratory rate is very. What question? Didn't say please a word of reading or oh, she has a generic.
Then I would put
Decrease exercise tolerance. Yeah, exercise tolerance.
poor gas exchange. Probably. No, both. Yeah,
So would you just say dyspnea?
probably.
Okay.
I'm just asking. I mean,
Right?
Okay. Better, right?
Poor gas exchange.
And then you progress unilaterally.
I can't do that yet.
No, not poor gas exchange. Look at her oxygen saturation. 86%.
I don't know. Is there any occupation?
that's
That's really
Going
low.
by what David said, if a patient is on oxygen, then that's a big problem.
She's on oxygen. No?
Isn't she getting her treatment?
Oh, yeah, you're right. No, I would just put it. Her.
So decrease retention.
In this case, I don't know.
Also, do you agree?
Now I would put it third.
At the expiration.
Can you,
And
when we're done,
And I what?
when we're done, can you just go over how to prioritize core gas exchange? Like I've asked all three rooms and often didn't answer, so I'm still confused. Like to me, I don't know when it's a bigger priority than the ventilation.
I think it varies from case to case.
So yeah, in this case I would put it lower, I think. Because of the condition and stuff.
Yeah, I agree. I don't know. I feel like it's
I'll put it third.
I feel like she's just me also possibly because of lack of oxygen. So what does that mean?
I think she's dyspneic because of her respiratory
Yeah, that too,
rate,
but-
limited chest
Well, she's
expansion.
not getting enough oxygen. I never know where to put it. Like, to me, it's always a higher priority. I agree to increase retention.
No, in the last case we put dyspnea as a higher priority than core gas exchange.
But again, I was questioning it because I never know when to put it. Okay.
Put it third for now. Put it third for now.
To me, I need to choose gas exchange. Like, I need to get them out of the.
Generalized for gas exchange.
Yeah. But I think I would keep them the technique first. That way, like throughout the treatment, you know, there's problems.
Sometimes, it's not, you don't have to get hung up about necessarily, one level or two. I think sometimes your treatment will address two things at the same time.
So. Unable to ambulate.
Yeah.
Just go with it. Barriers.
Is she going to school?
She's to get
Okay.
Just I read stopped exercising as a barrier. Yeah. And the fact that she has a genetic condition.
you have a genetic condition.
Huh?
Which is fun. I've reached that critical threshold point of focus.
Yeah.
About 2 hours ago, but it's just coming to.
No, my mind's on the ortho for today when I have to study.
School,
She stopped going, she can't go to school.
she's going. Oh, okay.
Oh, it says here, can go to school.
She's still doing good ID.
Oh,
no, she's not.
I guess not. Can't attend school.
Is there anything else compared to barriers?
Yeah.
The exacerbations?
Blood pressure, all that stuff.
No, well, maybe it's Is the exacerbation scores that are there?
I don't think so.
Multi-system? Actually, we have other organ groups. I'm gonna put it with pressure.
It's gonna affect the liver.
Is she lines and leads, obviously?
Low blood pressure, lines and leads. Yeah.
So how are we doing?
Did you come up with something?
I think our problem must start becoming too low. Well, yeah, well. Yep. Has infection.
She
Infection.
has sepsis.
Yeah, she. Yeah.
I think so.
She has an infection and she has an increased respiratory.
She has a fever. She has increased heart rate,
More than 2 seconds. Yes.
increased and an infection. So I think that's the definition of sepsis. 2 or more following.
That's why I think this is really important.
Time for this, guys?
Yeah.
No, Jen, you have to put it together. She's like, it doesn't say infection. I'm like, you have to put the pieces together.
She is infected. Oh, okay.
Something I
Okay, she
struggle
has
with on a daily basis.
Okay, let's wrap up. Have you identified all the plans? I don't think you've tackled treatment.
No.
No, yeah, because we wrote so many problems.
David was talking about. She's pain, but it's also like David. Does it really work or is med better? Okay, we're gonna put med star and splinting probably.
You're at your OSCEs, you're about to enter the room, identify what you would do.
Deep breathing.
Deep breathing for myself and
Deep
Postural
breathing.
drainage.
Deep
Together.
breathing. Range of motion. Mobilize is tolerated.
honestly, I would just suggest like this.
I'm just trying to add some pressure here.
Like if you look at
Okay.
No, you can't do those
Thinking
things.
about priorities.
She has like widespread secretions. I think you have to do more like.
After like postural drainage, you're coming up once you finish the segment.
I should put it as elevated.
Right, because you're gonna do postural drainage.
Would you have it?
Yeah.
Yeah, I think so too.
So you can't do any like copying.
Oh, cool. Hey,
I memorized that.
We're working on secretion.
that's from last year.
She said it again.
Yeah, she keeps going over and over and over again, and like my brain.
I wrote the
every time I'm like, nope, ignore
I
it.
wrote the contraindications down like 4 times.
I don't even know.
I opened up PowerPoint.
The list was long. I have a rule. The list is long.
So the one that's what I call a contraindication.
No, I only remember the one you said. There were 6 ones. No caffeine. First left breathing. Forward lean position.
Is there any kind of adaptation? Yeah, change positioning, is there any? Her pneumothorax on the right?
So either upright positioning or sideline.
She's wearing, she has like a venturi mask, so didn't Kara said that the person breathing.
Okay, so it's really recent.
Yeah, I don't know.
Yeah, like upper lip.
Like
So I don't think
no.
Upright positioning or sideline. What side's your pneumothorax?
drainage is okay. Oh, no, you can't.
this is becoming a better method. And you said seated and semi-reclined, right?
The secretion devices, they continue with that. Okay, what about
Decreased chest expansion, ventilation, deep breathing. Where is the decreased chest expansion?
Bilateral on inspiration. I think
Where is it, Jerry?
there's a bilateral.
Does it say specify where?
No.
Okay, next issue.
Decreased
Should we just
mobility.
say shortness of breath will
Ankle pumps.
and
and she has limited chest extension or something like that. Again, still some diaphragm.
Maybe you
Okay, so
mobilize
let's wrap
the
up
patient.
and let's get one of you to tell me your problem list.
Okay, for us, we put pain as first or chest pain.
Okay, I need to know what you guys put.
That as well.
Same thing. Pain,
Yeah, pain.
okay, then?
And then we put secretions retention.
Same. Yeah, same.
And what'd you put as third?
Shortness of breath at rest.
That's two.
This one.
Okay, so you're telling me that you're gonna clear those secretions no matter how short of breath this patient is? Shortness of breath, you really need to deal with the shortness of breath, and that's gonna limit you potentially with anything that you try to do. That is one of the priorities, right? The patient is sitting up in bed, okay? Rapid breathing. She's looking a bit distressed, she's short of breath. Okay, what do you have to think about first?
Getting her to calm down and bring down her breathing rate.
So the dyspnea, right, is important. So what may you suggest for dyspnea?
First like breathing.
First lip breathing,
Positioning.
Positioning.
positioning for dyspnea.
Isn't the dyspnea caused because she has a lot of secretion so that prevents gastric changes?
But you won't be able to clear secretions on somebody who's super short of breath before you try to help them with their shortness of breath. And if, she's desaturating, she may need positioning, she may need some supplemental oxygen, okay? And yes, you're gonna do secretion clearance, but you need to be careful because she is awake, she's not, sedated, she's not paralyzed, she's not intubated, she's short of breath. She's gonna tell you to go fly a kite if you're gonna wanna start, aggressively doing something with her. So we just need to acknowledge the fact that shortness of breath and distress has to be dealt with first, okay? You need to think about that. And it may limit what you may or may not do with the patient, right? If somebody's very short of breath, they may not tolerate head down, for example. Okay, so that's why it becomes such a priority. And you have to work within it. Pain, I agree, but pain, I might even put second to the dyspnea at this point. To me, her shortness of breath is a priority. This isn't a surgical patient, where the pain may be a number one priority because of their incision. She's got pain from the chest. So yes, it's, something that you need to deal with, but her shortness of breath to me is kind of, number one. If she's on pain medication, you can take a look, make sure that you're, for sure, optimizing her pain management before you see her. And what could you offer for the pain that she, because of the chest tube? Treatment for pain, splinting, right? So I would suggest that dyspnea is number one. Number two would be pain. Number three, secretions if you want. What's number four? For gas change. And you know, you can have a discussion also, would you put poor gas exchange as third versus secretions as fourth? You know, it's kind of the chicken and the egg, they're both kind of related here as well, all right? And then chest expansion, decreased chest expansion. What do you have?
We put, yes. Oh yeah, decrease ventilation. We put for forward foot and for gas exchange.
Okay, so you have impaired gas exchange, and do you have decreased ventilation? Okay, so you just have chest expansion, not ventilation. Okay. But she has decreased, she has shallow apical, right, breathing. And she's got limited chest excursion on inspiration bilaterally. So she's probably got decreased ventilation happening. I would suspect even, especially in the base of the lungs, basically, because she's using, you know, more apical breathing. Now the chest expansion, you were considering it as what? Was it more of the ventilation issue, or you were thinking more of the sort of the actual chest mobility issue, or?
Yeah, chest mobility. We thought like maybe the fibrosis of the tissue of the lungs that was limiting the ability to expand.
Okay, so the chest mobility, because of, it's not just fibrosis, it's also obstruction, right? This is an obstructive lung disease. So, it's a combination basically. And in CF, there's the issue of osteoporosis also, so that may contribute a little bit also to poor posture. But the disease itself, the hyperinflation, people have very stiff chests. Okay, the chest wall that becomes stiff. So the chest mobility, decreased chest expansion is also separate because it's decreased mobility of the chest. You had your hand up.
Why are we prioritizing ventilation before chest expansion?
A rigid chest versus ventilation. It's not the rigid chest that is just contributing to the ventilation. It's a ventilation problem. And then, what else do you have?
We said increase work of breathing access.
Okay. That would be, if you really wanted to, that's like part of the dyspnea as well.
Yeah.
So it's pretty high up, right? And so decrease will risk of DVT, okay, and
then afterwards we put like, generalist fatigue, decreased exercise tolerance.
okay, so decreased exercise tolerance or decreased exercise endurance, right? Poor posture,
Mm-hmm.
We put that at the last.
all right. And what else? Anything else? What about the fact that you can't climb stairs or a hill?
Put that after the activity limitation.
Okay, but what is it as an impairment? How about decreased strength? It may be also decreased strength. It's something that you can measure. That's something that you need to consider. Especially since you had, what does it say? Fatigue of the, light fatigue after climbing the stairs. Okay.
How would you prioritize between posture, muscle fatigue, and decreased exercise?
It really doesn't, I think the endurance and the strength go last, and the poor posture, maybe before. It really doesn't, I mean, you can split hairs there, it really doesn't matter, I think it's kind of, they're all something that you may wanna start working on, but something that is also long-term, right? In terms of exercise endurance, it's something that you're gonna need to optimize, so that when she gets back home, that she can continue that training as well. Same thing for posture, same thing for strength. Right? Then for activity limitation, what do you have? Stairs, walking, what else? ABLs, right? What else? Ladder.
We said leisure, soccer, and they're not attending school right now, I guess, because they're in the hospital.
Okay, I think you guys have the same thing. Anything else? Okay, and then personal environmental?
Just stopped exercising. Distress, we wrote multi-system.
Organ failure.
Lines and leads, decreased blood pressure, fever, infection, increased heart rate.
Sepsis. Also.
Sorry?
Has sepsis.
Okay, well, we're gonna talk about that because I'm not sure that you would put that into personal environmental. If you wanted to put anything, probably fever, malaise would be the limiting factor. I mean, whether she has SIRS or sepsis, or is that really going to change your treatment? No. I think the malaise and the fever, and it's really the how she's feeling, right? Is what you can do with her. She's not feeling very good at doing anything that can limit your treatment, right?
So then another one that avoids exercise.
Well, avoids exercise, okay. Okay, keep that in mind, remind me if we don't tackle that in a second. Anything else in your personal? Okay, what about her, the IVs? Is that it? Face mask? Chest tube?
Oh, we also said she's unable to speak.
Unable to speak due to shortness of breath. We had it under shortness of breath, so the unable to speak is not really. What about her diabetes? Somebody who's on insulin, especially if they have a fever, they have an infection, sometimes their diabetes is a little bit more challenging to control. So when you're doing exercise with these patients, you want to be able to make sure that they're able to monitor the sugar with that. You know, somebody monitors their sugar. Because with exercise, they can become hypoglycemic, so we need to be careful with that. Anyone had sort of a little bit of anxiety relative to
Or put stress.
stress? Okay. So fever, malaise, you were tackling it as sepsis, and I saw her increased heart rate, and what else did you say? These are all signs. Remember, these are all signs, right? You're not going to put signs in personal factors. Okay. So if it's because she's got an infection and she's had a fever, that's one thing. Okay. You know, if it's a high heart rate, we're going to debate whether who could increase heart rate. Well, okay, you can monitor it. You know, does it affect your exercise? Yes, but it's also partly she's got a fever, was probably also contributing to the increased heart rate. You know, if you put it down, and it's an issue in terms of monitor relative to activity or exercise. Okay, fine. But the same goes for saturation, for example, right? Is poor gas exchange, are you going to put low SpO2 in your problem list? You're monitoring it. So that's why respiratory rate you would put in there, heart rate, maybe not. Medications, the other group had put as well. I wanted to mention that. I wouldn't put medications per se, aside from maybe, like we said, diabetes, the insulin business, so sugar. But maybe in this situation, it's the steroids. And the steroids also, you have to think about then what? Muscle weakness, but also potentially osteoporosis. And that's a problem with CF that you're probably not aware of. But because they have poor absorption in terms of the fat, the osteoporosis is a problem. So that's how it also contributes to poor posture. So this is something that you need to be aware of. So weight-bearing exercises are good with these patients. So stairs maybe at work is an issue, right? They have stairs. Now, You mentioned that decreased physical activity or decreased avoidance of exercise. Okay. Keep in mind that again. What's the main thing that you would want to do with this person? First thing.
Dyspnea,
Okay, dyspnea.
and then like secretion.
What about dyspnea?
Oh, like
Dyspnea is just your problem.
pursed breathing, forward lean position, relaxation.
Okay. And with increased activity, what else could you do then? Controlling breathing and activity, what do you call that? Paced breathing, yeah. And then down the line also, obviously, energy conservation. Okay. What else? I guess the question, yeah.
We just mentioned first the breathing with this one, really big for the nutrient mask.
Sure.
Like I know they're really bad at this and no.
Right, because the BiPAP is just pressure, so it's more difficult, but sure, the oxygen, supplemental oxygen. Would you do any education with this patient? Is there education to be had? So what would you do with the decreased decreased exercise? Would you educate?
Yes.
Anyone else? Okay. One of the things that you need to keep in mind is that this is a genetic disease, a chronic disease. This is something that somebody was born with that they've had all their life. Okay. In terms of the exercise that they do, there's probably a regimen that they are on, and she's probably very aware in terms of the secretion clearance that they have to do. They've done it all their life 3 times a day. Vest clapping is sort of the traditional, but then they go to the vest and the acapella for trying to get independence. Physical activity also, and exercise per se can be used as secretion clearance in these patients. So often they increase the amount of exercise that they do in order to try to help promote secretion clearance. So, you know, the climbing up the 5 flights of stairs that she does, and climbing up the hill is probably because she's aware of needing to do that exercise in her condition, okay? So one of the things I wanted to bring up in this situation is that education, you know, although we do a lot of education in patients who develop a condition that we may not be aware of, oftentimes when it's a genetic condition, they are very aware of everything relative to the condition, maybe even more than you are when you go and see them, okay? So the restriction in the physical activity, although I agree with you that it was there, she probably limited herself simply because of all her symptoms that prevented her from being able to. But I agree with you that it's a problem when you have that in terms of the activity limitation, you know, when you're starting to drive and wait and not being able to probably do stairs. That would be the activity limitation. So it's a good point to raise, because I think we need to be cautious when we're educating patients who have the disease all of their life, and oftentimes you'll need to try to gauge at sort of a need basis, you know. And one of them said, well, you know, we'll only provide them with answers if they ask questions. Well, maybe not. Maybe what you need to do is ask questions to try to gauge whether there is a need, all right? And then provide that education if there's a gap in there that we can fill. So that's just something, you know, very important to think about when you're dealing with sort of lifelong chronic diseases when you have somebody who's 25 and like that. The other thing in terms of education is also that you have maybe end-of-life issues that will come up, okay, that may need to be tackled. Also referral maybe to a psychologist, right, because it's some of the anxiety and fear and all of that potentially as well. What else? Secretion clearance. One important thing in terms of secretion clearance, what would you do?
As a treatment, or?
Yeah.
Well, you can't do clapping because of it. pneumothorax, but you can do partial drainage, puffing, coughing.
Do you do vibrations? Would they do the vest? Would they do vibratory PEP? One of the big things is the hemoptysis. This is, she came in with 215 mils of hemoptysis. This is like hemorrhaging inside the lungs. So when they come, they have to stop any sort of manual techniques, the vibrations, the vest, a cappella, no clapping, no vibrations. Deep breathing is fine. Puffing is okay. Coughing supported because of the chest tube. So the postural drainage, what would be dependent is what her tolerance. It's the dyspnea that may limit you in being able to do that. That's what you're going to have to see with this patient. Okay. For the secretion clearance, so if sometimes what they have to do even because they take them off sometimes anti-inflammatories because it inhibits platelet function, and you need a clot being formed there, right? So that there's less hemorrhaging happening because it's the bronchial vessels that are bleeding at that point. Sometimes what they need to do, if the patient only comes in for hemoptysis, because it can happen, it happens often with CF, is they may put them on antibiotics because if they have blood in their lungs, it's just a good medium for an infection. She already has an infection, so she's on antibiotics. Sometimes if they have a lot, they have to go through the bronchoscopy and actually cauterize the vessel, okay? But until that hemoptysis reduces, and I'm saying that there's scant hemoptysis, less than 5 mils, then there's a discussion with the doctor, actually when do you start with more secretion clearance techniques. So active cycle breathing in that case, and you're right, because of the pneumothorax as well. So, but deep breathing, right, lateral costal diaphragm, because she's using a lot of apical breathing in this situation. And what else would you do? What's key now also with her? In acute conditions in the hospital, what do you try to promote as much as possible? Mobilization. Right? And how do you mobilize the patient? Again, tolerates, monitoring, all of that, but
Transfers, ambulation.
standing, she's probably physical function, she's young, right? So it's not going to be limited. So it's trying to get her to walk as much as possible, right? Initially walking in the corridor, getting the stairs, maybe cycling. Like this is, it's initiated already in the hospital. It's clearly limited right now by your dyspnea and your saturation, but as the secretions start to move out and you're limited by the hemoptysis, once that sort of starts getting resolved, it's really trying to get her as much as possible back to physical, right? Increasing physical activity, trying to get her to walk, to exercise, and then long term, what do you want to do in terms of a program for her? Because she may have reduced, we said, endurance, maybe reduced strength. So what do you do with this patient?
Maybe want her to get back into walking to school and doing more physical activities. So maybe working on her endurance and whatever she can do for muscle strength.
So yeah, muscle strength. So training the muscles. And if you wanted to do an aerobic program, to try to get her to do more, what might you emphasize? What kind of exercise? I mean, she does a lot of walking, so it could be treadmill, right? She does stairs a lot, so it could be elliptical, right? Things like that. And how do you monitor? Like, what do you use in a training program with a patient? Usually for exercise, we're talking about pulmonary rehab. What are the sort of 2 parameters we use most often? Exertion, RPE, or dyspnea, right? And heart rate. Okay. So dyspnea, we're trying to keep it between 3 and 5 usually. Sometimes a little bit higher if we do more high intensity exercise, more intermittent, right? More HIIT kind of stuff. So you think about that as well. And how do we use heart rate? What percentage? It's either percent heart rate or heart rate reserve, right? We're gonna be looking at that a little bit in class, but it's heart rate reserve, the resting, and peak, and a percentage of. So what percentages are we looking at? 40 to 60 starting off, and then progressing to 60 to 85, right? But for her as well. And strength. Yeah. So using, either heart rate or dyspnea or both, right? I think that's it. Oh, and no, one last thing. Because she has a lot of secretions, one thing, like in the bronchiectasis case, urinary incontinence, you have to think about it in this case too. And I had a summer project, a group 2 years ago, who did looking at sort of complications in CF, and urinary incontinence can happen even in kids. So it's something that you need to be aware of when people have chronic conditions that are coughing all the time. So Kegel exercise, the pelvic muscle to try to, like when you're holding your urine, those are the Kegels, to teach the Kegel. For them to do the Kegel even before they're coughing, it helps. And maintaining a straight posture also helps. So that, we often don't think about enough about that, but we need to be aware of that. And they won't tell you, you need to ask. Patients won't tell you that they're having these issues. So sometimes you can refer them, there aren't experts in terms of Any questions? And of course, posture, and chest mobility exercises.